So welcome again to yet another session, which will be on diabetic kidney disease. There is a paradigm shift in the understanding of diabetic kidney. So you will be surprised to know some of these changes. So when I read through the last 3-4 days, I find myself a lot of updation is required in my earlier presentation. So this is that one. Diabetic kidney disease, the modern clinical paradigm, deconstructing the pathobiology and escalating to precision management. A high level synthesis of recent paradigm shifts, updated guidelines, and complex pathobiological framework. Diabetic kidney disease definition, etiology, and global burden will be the first part. This talk is divided into 4 parts. The first part is about the etiology, definition, and global burden, etc. Now you see there are 4 aspects here. The cognitive journey through diabetic kidney disease, a zoom lens approach. First one is at the macro level, global epidemiology, what is happening, exploring and escalating the burden of the socio-demographic disparities between different countries and utilizing the GBO 2021 data. The second one is, of course, the clinical level. First is the epidemiological level, macro level. The second level is the clinical level, the nomenclature and the definitions, establishing the strict diagnostic dichotomy between 2 important entities here, diabetic kidney disease, DKD, and the histopathological diabetic nephropathy, DM. Diabetic kidney disease is a clinical diagnosis. Diabetic nephropathy is a pathological diagnosis. You must clearly understand the difference between the two. And third level is the micro level, the pathobiology level, pathophysiology level. So deconnecting the converging stems of the 2 things, that is the diabetic kidney disease and diabetic nephropathy. And finally, the clinical synthesis of the phenotypes. There are 2 phenotypes you can see. One is the clinical presentation in a diabetic patient with proteinuria. The other one is kidney failure or kidney disease without proteinuria. So there are the 4 levels of understanding. Now you can see the global burden. In terms of the global burden, you see a prevalence explosion 445 million in 1990 has now become 137.5% increase to 1.08 billion in 2021 all over the globe. That means from 455 to 108 million, we have increased in the prevalence of diabetic kidney disease. Incidence velocity, 16.2 million incident cases occurred in 1990, surged to 44.9 million, again a 177% increase. And the core drivers are, why is it happening that this epidemic of diabetes along with the diabetic complications is increasing? There is a demographic shift, the population growth and global aging. People are living longer compared to about 40-50 years back. And also unprecedented rise in the T2DM related CKD complications because of the accessibility of the care and diagnostic facilities. From 1990 to 2021, not long ago, 30 years is the difference. Now you see the incidence burden, high SDI regions. SDI is standardized incidence rate. As age standardized incident rates have peaked now. And second one is the driven primarily by the extended life expectancy and the Western type of lifestyle now. Concentration factor. China, India, United States, and Japan account for about 70% of the global incident cases. These 4 countries, China, India, very populous countries, United States because of the type of food they eat, and the Japanese also are now added onto the diabetic kidney disease. The mortality and daily daily burden. What is daily? Daily is disability adjusted life years. So the ASIR, age standardized incidence ratio, is lower 15.09 per 100,000. Earlier it was 23.07, but the disability adjusted life years and mortality rates have heavily skewed towards low and low socioeconomic countries, driven by late diagnosis, resource limited healthcare systems, and lack of access to foundational therapies. Okay. Now, the global daily reached around 123.7 million in 2021, a 153% increase since 1991. Disability adjusted life years are increasing. There is a shift in the mortality and also in the daily burden. Now, CKD and diabetes and diabetic kidney disease. As I have told you, chronic kidney disease and diabetes is one aspect, diabetic kidney disease, a paradigm, a pragmatic, conservative clinical descriptor as per the KDIGO, abnormal kidney filtration and excretion markers in the setting of long-standing type 1 or type 2 diabetes. So what is the definition? Long-standing type 1 or type 2 diabetes should be there. And abnormal kidney filtration like reduction in the EGFR and excretion marker means proteinuria in the setting of a long-standing type 2 diabetes or type 1 diabetes. Implications are makes no assumption regarding the underlying predominant mechanism. This clinical definition makes no assumption about the predominant mechanism, often excludes patients with known, clear, alternate causes of kidney disease. That means a diabetic person, other causes of kidney disease also may be there, which can produce nephropathy. What is the diagnostic reality? Because routine kidney biopsies are not done. So normally for diabetic kidney disease, who does a biopsy? They don't do it. Because you are not doing a biopsy or are not justified in the standard diabetes care, diabetic kidney disease serves as an essential operational diagnosis or clinical diagnosis with albuminuria and reduced EGFR for clinical trials and routine population management. That being so, now we have two entities, DKD and DN. As I told you, DKD is a clinical and pragmatic, and then DN is a strict histopathological diagnosis. DKD, diabetic kidney disease, CKD is chronic kidney disease, DKD is diabetic kidney disease. Diabetic kidney disease is a clinical diagnosis, where diabetic nephropathy is a histopathological diagnosis. What is the DKD? Functional impairment of EGFR decline less than 60 ml per minute per 1.73 meter square and or persistent proteinuria, albuminuria, urine albumin creatinine ratio more than 30 milligrams per gram. So two important variables, EGFR should be less than 60 and urine albumin creatinine ratio more than 30 milligrams per gram. This is the clinical criteria. Whereas diabetic nephropathy, pathognomonic renal structural abnormalities confirmed by exclusively kidney biopsy. There are three important areas, the basement membrane and the mesangial matrix and also the nodules. We will see in the next slides. That is the histopathological diagnosis. Now, kidney identifiers, estimated functional markers, cardiovascular risk factors are there, the key identifiers for the DKD. There, and diabetic nephropathy, we have got Kimmel-Steele-Wilson's nodules, GM thickening, and podocyte effacement are the three important fundamental pathological changes. Now, clinical utility, routine screening, population health, and primary trial endpoint definition. The clinical diagnosis. But in an individual patient, reserved for resolving the atypical presentations, rapid EGFR deterioration, sudden proteinuria, high proteinuria, active urinary sediment. Now, we are caught up in a dilemma. One part is the clinical diagnosis, which is the diabetic kidney disease. The other is diabetic nephropathy, which is histopathology based. Do we really need to distinguish them? Yes. As you can see here in this slide, What are the pathological lesions in diabetic nephropathy? Number one, glomerular basement membrane changes. Thickening in the glomerular basement membrane is the earliest ultrastructural lesion in diabetic nephropathy, detectable in a diabetic nephropathy driven by non-enzymatic cross-linking of the collagen 4. What does that mean? There is collagen 4. There are several collagens. Out of them, collagen 4 is one, which is there in the basement membrane. Thus, basement membrane should be permeable for the fluid. This non-enzymatically, the cross-links are formed, the basement membrane becomes thicker and relatively sort of non-functional. Okay. Now, podocytes. Podocytes we have seen in nephrotic syndrome, cytoskeletal reorganization and epithelial mesenchymal transition leads to the food process loss and food process effacement. I have shown you in nephrotic syndrome that leads to physical detachment of the podocyte from the basement membrane and the fenestrations are lost. Leak occurs, proteinuria occurs. Third one is mesangial matrix expansion culminating in the formation of a nodular glomerular sclerosis, classical KW lesions, Kimmel-Steele-Wilson lesions. So glomerular basement membrane thickening and then the podocyte effacement, KW nodules are there. And there could be some tubulointerstitial changes also. You see the basement membrane here. This is the podocyte effacement. These are the KW nodules. And you also have tubulointerstitial compartment, advanced tubulointerstitial fibrosis and tubular atrophy alongside arteriolar hyalinosis signaling the irreversible nephron loss. So all four are the various pathologies. GBM thickening, podocyte effacement, KW nodules, tubulointerstitial atrophy and fibrosis. Now, as far as the pathology is concerned, from the biopsy, we can classify them into four classes. Class 1, 2, 3 and 4. 1. Isolated GBM thickening detectable only by electron microscopy. 2. Divided into A and B, mesangial expansion, and that leads to mild to severe affecting more than 25% of the mesangium without nodular sclerosis. This is 2. And 3 is the nodular sclerosis is there, Kimmel-Steele-Wilson lesions, focal lobular mesangial lesions with a cellular core, just like these things. There are no cells there. This is a nodules there. And 4, advanced diabetic glomerular sclerosis, global glomerular sclerosis of more than 50% of glomeruli. So class 1 GBM, class 2, only they have mesangial expansion, class 3 nodules, class 4 glomerular sclerosis. Clinical utility note, biopsy remains vital in atypical presentation and for untangling advanced mixed etiology. What are they? We will see. You can see here. Pathophysiological mechanisms in DKD progression, the converging storm, glomerular hemodynamic alterations, that means vasoactive shifts driving severe intraglomerular capillary hydraulic pressure and hyperfiltration. That is, glomerular hemodynamics are altered. 2. Metabolic cascades, intracellular glucose by bypassing glycolysis, activating the destructive alternative pathways like polyol pathway or advanced glycation and products pathway or protein K C pathway. Okay, inflammation and immune pathways. Innate immune activations, cytokine release, and macrophage infiltration driving the fibrosis. All three lead to progressive renal parenchymal damage. Number 1, glomerular hemodynamic alterations, increased intraglomerular pressure and increasing the leak, metabolic cascade like polyol pathway, AGEs and PKC, and immunoinflammatory pathway. Now you see this is the afferent arteriole, this is the efferent arteriole. What is the hematology changes? What are the changes in the glomerular injury and hyperfiltration mechanisms? Number 1, chronic hyperglycemia. For a long time, chronic hyperglycemia triggers local vasoactive mediators. What are they? Nitric oxide, prostaglandin, glucagon, VGF, forcing the afferent arteriole to become wide open. That means the entry channel is wide open. So much so more blood flows into the glomerulus. Now, the efferent arteriole is constricted. Why efferent arteriole constricted? Because the outflow is constricted. Intrarenal ROS activation generates elevated angiotensin II, a potent vasoconstrictor, clamping the efferent arteriole. Then what happened? Outflow is obstructed, inflow is increased, intraglomerular pressure increases. Result: the combination of massive inflow with restricted outflow spikes capillary hydraulic pressure inside the glomerulus. This causes physical shear stress, injuring the podocytes, shattering the filtration barrier, and initiating the protein leakage. The podocyte effacement occurs, basement membrane is thickened, basement membrane is subject to stress, and the filtration barrier is affected, and protein leakage starts. So, understand, this is the mechanism of glomerular injury. Now, what are the chronic intracellular hyperglycemic pathways? We divided into three. First one is glomerular injury, as we have seen, intraglomerular hyperpressure, and which is leading to all the three changes like basement membrane changes, and then the podocyte effacement and the protein leak. And the intracellular glucose is now taking other routes than the glycolysis. Polyol pathway is there. Aldose reductase converts excess glucose into sorbitol and fructose. There will be osmotic stress, oxidative damage, accelerated cross-linking of type 4 collagen, which further damages the glomerular architecture. 2. Advanced glycation and products. This is because of the reactive oxygen species there, upregulation of the TGF-beta, driving the mesangial cell proliferation, and chemosterilis, nodule formation. Finally, PKC activation, protein kinase A activation, driven by the DAG formation, and the ROS, the reactive oxygen species. DAG is diacetylglycerol. This results in overexpression of the fibrotic growth, TGF-beta 1, leading to massive type 4 collagen and fibronectin synthesis. All these result in extracellular matrix changes and accumulation and glomerulosclerosis. So what happened? In the previous slide, intraglomerular pressure increased, protein leak, basement membrane changes, and podocyte effacement. Chronic intracellular hyperglycemia, polyol pathway, advanced glycation and product pathway, protein kinase A activation, all these three unfavorably work on the glomerulus and extracellular matrix, and accumulation, extracellular matrix accumulates, and there will be glomerulosclerosis. Now, inflammasome engine, the third aspect is the immune inflammation. So there is an endothelial cell there, and then there are sensors, TLR like receptors, Toll receptors, and then the NLR domain receptors, and these sensors activate the macrophages, and NLRP3 inflammasomes convert inactive interleukins into biologically active and highly destructive forms. Inflammasome engine is activated, and then finally cytokine assault occurs. These cytokines are released there from the macrophages through the endothelial activation. Whatever cytokines are formed, these cytokines are injurious to the glomerulus, interleukin 1, interleukin 6, and tumor necrosis of factor alpha. They all act as immune inflammation. Okay. Is there any genetic variation? Yes. On top of these, there is a genetic susceptibility. DKD is not purely a product of lifestyle or duration of diabetes. Let us say somebody is obese, diabetic, 30 years, has got 20 years diabetes, develops DKD. Yes, sure, but there is a predisposition. If a first degree relative with both diabetes and DKD functions is there in the patient, that is a massive genetic multiplier signifying raising the patient's baseline risk. So always look at the family history of diabetes in father, mother, other sibling, and DKD in them or end-stage renal disease. There is also called epigenetic metabolic memory. You must have understood this. Around 20 years back, we started understanding this metabolic memory. The phenomenon is where the cellular damage persists long after the euglycemia is achieved. That means what? Initially, a patient had very high levels of blood sugars, hyperglycemia. He did not control well his diabetes in the first 5 to 10 years. There is a metabolic memory. Later on, he became active, took insulin, controlled his weight, reduced his sugar, but the initial hyperglycemia is giving rise to a metabolic memory in the cells. Though presently he is euglycemic and well controlled, if initially a person is ill controlled in the first 5 to 10 years of diabetes, there is a metabolic memory and there is a permanent epigenetic modifications on the genome, locking the cells into an inflammatory and fibrotic transcription patterns, regardless of the current A1C levels. This is very well understood around 20 years back itself. We were teaching this. Now it is all the more valuable and useful. Metabolic memory. What does that mean? There must be strict diabetes control immediately after diagnosis in the first 5 to 10 years. If you have not done that, even later on, even if you control the diabetes well, the metabolic memory will produce a lot of problem for the patient. So what are the things we have now summarized? Now, in the pathology, we have got in the pathology, there are alterations in the there are vasoactive shifts driving the severe intraglomerular capillary hydraulic pressure, and metabolic cascade is there bypassing the glycolysis, the polyol pathway, the AGEs and the protein kinase C pathway, and inflammasomes working for the immune inflammation, all causing progressive renal parenchymal damage. So the afferent arteriole is widened or dilated, efferent arteriole is locked because of the RAAs, intraglomerular pressure increases, more filtration, basement membrane damage, and effacement of the podocytes. Now we have got the intraglomerular pressure increase. This is one aspect. The second aspect is glucose is not metabolized by the Krebs cyclic glycolysis pathway. Instead, glucose is taking the pathway of polyol pathway, advanced glycation and products, protein kinase C activation, all increase the extracellular matrix and accumulation and glomerulosclerosis. And then finally, the inflammasomes, NLR, P3, and TLR like receptors of the endothelial cell, they excite the macrophages and produce various interleukins like the IL-1, IL-6, and TNF alpha. These will produce a cytokine assault on the glomerulus. So, net result is, on top of that, there is genetic susceptibility and the epigenetic metabolic memory. Finally, two types have emerged. Diabetic kidney disease is two types now. It is not one type as thought of earlier. One, the classical proteinuric DKD, where diabetes is there long-standing, proteinuria is there, and EGFR and has decreased, creatinine has increased. This is the primarily driven by glomerular damage, hyperfiltration, podocyte loss. Clinical marker, progressive albuminuria. That is called the proteinuric type of DKD. There is another DKD called the non-proteinuric DKD or NPDKD. Just like you have, ejection fraction, decreased heart failure, ejection fraction, preserved heart failure. Two types we are seeing in heart failure. Here also, DKD with proteinuria, DKD without proteinuria. This is called non-proteinuric DKD. But this is a new entity, almost last 10 years, and not even that. 5-6 years. Non-proteinuric DKD, the pathophysiology is primarily driven by the vascular and tubulointerstitial. It is not glomerular disease here. Glomerular disease is here in these people. Here it is the proximal convoluted tubule and then the tubulointerstitial mechanisms often occurs with zero evidence of glomerular pathology. There is no glomerular pathology, there is no albumin leak, there is no basement membrane thickening, there is no mesangial hypertrophy, there are no Kimmel-Still-Wilson's nodule, but patient has got nephropathy. Why? Because of the vasoactive tubulointerstitial mechanisms. What is the clinical profile of these patients? Patients are typically older, more frequently females, present with profound microvascular complications like retinopathy, okay, face significant cardiovascular morbidity despite a slower renal decline. You understand? These people are elderly people, women, profound microvascular disease like retinopathy, and face significant cardiovascular disease and cardiovascular morbidity despite the kidney progressing slowly. Now let us see the continuous loop of irreversible nephron loss, hyperfiltration, shear stress, damage to the filtration barrier. Okay, triggering the ROS production, mitochondrial dysfunction, TGF beta release. This is the inflammasome or the cytokine there, which activates the NLRP3 inflammasomes and cytokine assault, interleukin 1 and TNF alpha. All these leading to tubulointerstitial fibrosis, nephron dropout, increased mechanical strain on remaining nephrons, leading to back into hemodynamic stress. This is the summation of this continuous loop of irreversible nephron loss. Now, there are three aspects now. An exploding unequal global burden on one hand. We have got an exploding unequal global burden. That means in some countries it is much faster, in other countries lesser. And also there are disability adjusted life years. DALYs are increasing. Second one is precise ontological boundaries. DKD is our vital clinical pragmatic umbrella under which you must screen screening must evolve beyond the albuminuria, because we have an entity called non-proteinuric diabetic kidney disease, NPDKD. Just looking at the albuminuria and EGFR alone may not pick up diabetic kidney disease. You must look for NPDKD, non-proteinuric phenotype. Now, multifactorial imperative disease is not a single pathway, but a converging storm of hemodynamics, metabolic, inflammatory engines locked in the epigenetic memory. True precision medicine requires dismantling all three mechanisms simultaneously and attacking all the three, correcting the hemodynamic abnormality, correcting the metabolic abnormalities, addressing the inflammatory engines, and also trying to treat diabetes early to prevent the bad epigenetic memory, which I have already explained. This is called precision medicine. Okay, now this is the second part now. Hitherto is pathophysiology, etiology and all. Now it is clinical presentation, evaluation, diagnosis and advanced staging. So defining a disease, clinical syndrome versus tissue pathology, DKD, diabetic kidney disease, diabetic nephropathy, DN, these are not identical. DKD means a clinical diagnosis established by abnormal kidney filtration and excretion markers in the setting of a long-standing diabetes. What are they? Decrease in the estimated GFR, increase in the urine albumin protein creatinine ratio are the primary biomarkers here. Whereas in diabetic nephropathy, strictly histopathological diagnosis, as I have shown you, stage 1, only mild basement membrane changes, stage 2, mesangial changes, stage 3, Kimmel-Still-Wilson's changes, stage 4, glomerulosclerosis. That is the pathological stages, not clinical stages. A strictly histopathological diagnosis confirmed by kidney biopsy, defined by pathognomonic renal structural abnormalities. Now, what are the primary alterations? Glomerular basement membrane thickening, mesangial matrix expansion, KW lesions. Finally, more than 50% of glomeruli are sclerosed. This is the pathology part of it in terms of diagnosis. Now, the historical paradigm related to linear proteinuric pathway. Earlier, we used to say Mongensen's model, stage 1, hyperfunction, hypertrophy, supranormal GFR, reversible with glycemic control, stage 2, silent and structural phase, early GBM changes, GFR remains elevated or normal, stage 3, incipient diabetic nephropathy, the proteinuria started, raising blood pressure, stage 4, over diabetic nephropathy, macroalbuminuria, more than 300, and steady GFR decline, and finally end-stage disease. The historical assumption declining filtration was viewed as strictly dependent on the continuous escalation of albuminuria. What we were thinking, this decline from stage 1 to stage 5 is dependent upon the albuminuria, but it is not. Now there is an entity called non-proteinuric diabetic nephropathy. So this historical model will not always work. We are not saying it will not work. It is not always true. Standard DKD progression. Modern pharmacotherapy drives the emergence of non-albuminuric phenotypes. This is called the NKD, non-albuminuric, non-proteinuric DKD, NPDKD. Widespread use of renoprotective, cardioprotective medicines, ROS inhibitors, SGLT inhibitors has typically altered the natural history of DKD. What happened? Standard DKD over to proteinuria, classical pathway. Now what are we doing? We are giving SGLT inhibitors, we are giving ROS inhibitors. So much so the standard line is deviated like this into non-albuminuric diabetic kidney disease. That means the diabetic kidney disease is progressing, we control the albuminuria. Now, definition of overt proteinuria, persistent decline in eGFR while maintaining strictly normal urine albumin ratio. That means albumin ratio, creatinine ratio is normal, but eGFR is declining. Normally in classical pathway, what is happening? Both eGFR is declining and proteinuria is increasing. Now, because we applied anti-proteinuria treatment and vasoprotective treatment, we have stopped the proteinuria, but GFR decline is continuing. So now what happened? Epidemiological registries indicate NADKD now affects 20 to 40% of patients with diabetic kidney injury, up to 61% in some longitudinal cohorts. Now, there are now two classical phenotypes. Phenotype means clinical expressions. The classical phenotype and the non-albuminuric prototype, that is NADKD or NPDKD. You can say non-proteinuric or non-albuminuric. What are they now? Demographics, classical phenotype, more males, variable age, variable diabetes duration. Whereas here, NADKD or NPDKD more frequently. Females, older individuals, shorter duration, 3 years, 4 years, suddenly they go into nephropathy. Whereas classical fellow, 10 years, 15 years of diabetes is required. Modifiable risk factors, higher HbA1c is there, blood pressure need to be controlled, higher smoking rates in the classical type. Here, these are non-smokers, blood pressure is normal, HbA1c is controlled, favorable LDL and HDL profiles, but still they go in for nephropathy. And then, at the microvascular level, you have got what is called the microvascular complications strongly associated with diabetic retinopathy. Notable absence of diabetic retinopathy in these cases. Prognostic trajectory, high risk of rapid progression to end-stage kidney disease, low risk of ESKD, but extremely high cardiovascular mortality. What does that mean? The classical phenotype fellow is strongly associated with retinopathy and other microvascular complications, and he progresses to renal failure and stage renal disease. Whereas the non-albumuric fellow may not have diabetic retinopathy, older individuals, females, shorter duration, normal blood pressure, normal HbA1c, favorable lipid profile, but the end-stage kidney disease risk is very low, but very high cardiovascular risk for these people. We need to identify both types and prevent cardiovascular mortality and morbidity, and also prevent end-stage renal disease in this group. This is the current shift in the paradigm. Classical phenotype versus the NADKD non-albuminuric phenotype. Now you see here. Historically predictable, but no longer the only path. What was the historically predictable? Hyperfunction, then silent phase, then the incipient nephropathy, then overt nephropathy, and stage renal disease. This is okay. Around 50% or 40% of people will go like this. That is the classical type. But 50 to 60% of people will not follow this trajectory, and they had end up in more vascular complications, and particularly myocardial infarction, cerebrovascular accident will be there. That is the NA diabetic kidney disease, non-albuminuric diabetic kidney disease. Now, Tervier's RPS classification standardizes the glomerular destruction. Number one, mildest destruction, GBM thickening alone is there. Then classical 2, class 2 is the mesangial, A and B. A is mild expression more than 25 in the mesangium. 2B, severe expression more than 25 without nodular sclerosis. 3 is nodular sclerosis. 4 is the advanced glomerular sclerosis. Now, interdependent interstitial and vascular drive. Are these interdependent? The question is the classical phenotype and the newer phenotype without proteinuria. The interdependent interstitial vascular lesions drive the ischemic decline. What is it that is causing vasculature abnormality and making them prone for cardiovascular risk and vascular complications? Is tubulointerstitial fibrosis and tubular atrophy. Earlier it was not known. When I was teaching the same topic 20 years back or 15 years back, I never talked of the tubule being damaged in DKD. It was only the glomerulus, basement membrane, the podocyte, and the mesangium and the nodules. We never talked of tubules. Now, tubulointerstitial fibrosis, tubular atrophy, IFTA, chronic changes here are powerful, independent predictors of GFR decline in type 2 diabetes. Tubulointerstitial inflammation, functional impairment frequently occur early, sometimes preceding overt glomerular pathology. Glomerulus may be normal. Glomerular function, glomerular structure is not altered. What is the contribution of vascularity? Atherosclerosis frequently contributes to chronic ischemic injury, vascular stiffening, exacerbates the tubular fibrosis, and drives the non-proteinuric loss of filtration capacity. Now you understand the pathology behind NADKPD is tubulointerstitial fibrosis, tubular atrophy, and severe arteriosclerotic vascular contribution. What is the clinical synthesis? An NADKD phenotype is likely driven by severe interstitial and vascular ischemic damage occurring without massive podocyte destruction or basement membrane change or heavy albuminuria or glomerular damage. So what you have to do now? You have to look at the tubulointerstitium. How do I know that? Unless I do biopsy. Now what happens? In the clinical scenario, never we recommended kidney biopsy for diabetic kidney disease. Now, here is the case to do a kidney biopsy and classify the diabetic nephropathy, whether it is a glomerular disease or tubular disease, whether it is a classical presentation phenotype or NADKD. Why? The treatment is different. Now, come. Comprehensive case finding requires simultaneous dual biomarker screening. What are the dual biomarkers? You already know. One is the creatinine related to EGFR, the other is the albuminuria. Categories: albuminuria less than 30 milligrams, moderately increased 30 to 300, more than 300, severely increased more than 3000, nephrotic proteinuria. We know this. The second one is measurement of the functional nephron mass. How do I do that? Calculate the serum creatinine and validate the equations for the EGFR, CKD, EPA equation today. Okay, these are the two markers. Testing protocol: type 1 diabetes every year annually starting from the 5th year after diagnosis. Type 2 annually starting from the time of diagnosis. When do I do? Every diabetic who is diagnosed, mostly type 2 only. Type 2 annually we must measure EGFR based on the CKD EPI calculation and the microalbuminuria. This is imperative for you to prognosticate the patient. Now, KDIGO 2026 screening and diagnostic algorithm. What is that algorithm? Now you see. Test EGFR and albumin creatinine ratio. EGFR less than 60 or albumin creatinine ratio more than 30. Yeah, he is a case of nephropathy. Test again to exclude one time GFR low or proteinuria is not sufficient. At least 2 months apart, you must test again to confirm the CKD. Abnormalities persist for more than 3 months or earlier if chronicity is evident under the backdrop of a diabetes, chronic diabetes. Treat to reduce kidney and CV risk, manage risk factors, monitor the response. Okay, EGFR is more than 60 and proteinuria is not there. Who is this fellow? This fellow is not the classical type fellow, but the non-proteinuric type, non-albuminuric CKD. CKD not present and repeat annually. This is a classical understanding. Now, this person, today we should not be left alone. He should be followed regularly, and the moment he shows some renal function decline, biopsy has to be done. That is the thing. Now you see the matrix. The KDIGO 2D matrix is important. On one axis we have the albumin, the other axis we have got the glomerular function. Glomerular function more than 90, 60 to 89, 45 to 59, 30 to 44, 50 to 29, and less than 50. Classical 5 stages of glomerular function. Stage 1, stage 2, stage 3A, stage 4, and stage 5. In the albuminuria, less than 30 normal, 30 to 229 is the microalbuminuria, more than 300 macroalbuminuria. If a patient's EGFR is here and he has got no albuminuria, he is at low risk of CKD, the green one. Or if he develops albuminuria, or if he develops stage 3 disease, he is at a moderate risk of CKD. If he is in these, that is, he has got macroproteinuria or microproteinuria or 3B EGFR, he is at a high risk. All rest of them are very high risk for CKD. This matrix is very helpful. First of all, you do the two tests. What is the albuminuria like? That is the SER ratio and the EGFR, and see where the patient goes into this box, or anywhere else. This matrix categorizes patients for CKD progression and cardiovascular events and mortality simultaneously. This is the way you can easily identify who is at a greatest risk, who is at a low risk. Okay. Now what do? I have identified this pattern. What is my behavior as a clinician? What do? In this green zone, you prevent. In the microalbuminuria zone, you treat. In the macroalbuminuria zone or the GFR, you treat with 2. And then finally, treat and refer. That is 3. And treat and refer 4 plus. What are these 4s and all? You can see low risk, moderate risk, high risk, and very high risk. So depending on where is the patient, what is my treatment is decided. Okay, now 2026 KDIG update formalizes a conceptual shift. Chapter 1, focuses on case finding, staging, and primary prevention of cardiovascular kidney risk. Chapter 4 transitions from anti-hyperglycemic therapy to holistic comprehensive management. It is just not adequate to control the diabetes. You have to have a holistic comprehensive management to prevent progression into chronic disease and worsening down the line. Okay, now what do I do? First level, prevent, focus on primary prevention, metabolic control, test annually. Treat 1 and 2, initiate targeted cardio and renoprotective pharmacy, monitor 1 to 2 times per year these patients. Treat and refer 2 and 3, escalate therapeutic combination, monitor 2 to 3 times per year, consider referral for rapid progression. 3 and 4 plus, mandatory for nephrology, co-management, and definitely you should be prepared for advanced interventions like renal replacement therapy. This is called heat map. This heat map intersection dictates the dual focus of mitigating CKD progression while aggressively managing the inherent cardiovascular risk. Now, what are the kidney failure risk equation? KFRE. Every patient you see of kidney disease, you must get this risk. What are the inputs? What is the age of the patient? Gender, EGFR, urine albumin, creatinine. You punch these numbers. Validated predictive algorithm of 4 variables is there. This is available in the MedCalc. You just download MedCalc app and punch these numbers like in the age of the patient, gender, EGFR, and UACR. Then you will be given 2 outputs. What is the 2-year risk? What is the 5-year risk? If the 2-year risk is more than 15%, it is a serious condition. The 5-year risk is less than 30%, it is less serious. KDIGO limitations, KFRE utility, and clinical application should be borne in mind. Now, CKM. What is this CKM? Cardiovascular kidney metabolic health. There is a new chapter called CKM syndrome. What is CKM syndrome? Cardiovascular, metabolic, and kidney health. Rationale: DKD patient, especially non-albuminuric DKD phenotype, they are more prone for vascular insult. So what I have to do? They face a massive burden of cardiovascular mortality that outpaces the risk of end-stage renal disease. So that cardiovascular component is more. Then the kidney function has to be monitored and metabolic health. Now you integrate staging must incorporate the systemic risk. The American Heart Association CKM staging utilizes the prevent equations to calculate 10-year and 30-year atherosclerotic vascular disease. ASCVD and heart failure. The shift is, what is the shift? We have moved from nephron to organ isolate, which is an organ isolated specialty of nephrology, into a holistic cardiorenal medicine. There is a strategic shift from a nephrologist perspective into a holistic cardiorenal medicine. Who is best placed to practice cardiorenal medicine? Internal medicine only, because you are both cardiologist and nephrologist in the first run. That run you can take the inputs of people in both the specialties. Now, escalating risk, cardiovascular kidney metabolic framework. You see stage 0, no CKM risk factors are there. That means patient's BMI is normal blood glucose, EGFR is good, more than 60, prevent metabolic risk via lifestyle counseling. That is stage 0. Stage 1, patient is obese, adiposity is there, dysglycemia is there, overweight, impaired fasting glucose, target weight loss, and physical activity. There is no pharmacotherapy as yet. Stage 2, metabolic risks, early CKD. T2 started, hypertension is there, triglyceridemia is there, EGFR is in the grade of 3A or 3B. Goal, tight glycemic control, BP targets, initiate cardioprotection. Stage 3, subclinical CVD, high risk. 10-year risk more than 20%, high coronary artery calcium is there when you do calcium scoring, and aggressive lipid therapy, add NSMRAs and GLP-1 RAs. What are these? We will see in the treatment. And stage 4, overt cardiorenal disease, confirmed coronary artery disease, clinical heart failure, advanced stages of G4, G5 kidney disease, and advanced pharmacotherapy prepare the patient for renal replacement. Now, what did I do now? Using this cardiovascular kidney metabolic CKM framework, I classified the patients into 0, 1, 2, 3, and 4. The management is different between each stage. Okay, now. CKM staging and management objective. Stage 1, excess adiposity, dysglycemia, overweight and obesity management, individual lifestyling, and then weight loss. Stage 2, metabolic risk is there, type 2 diabetes, hypertension, hypertriglyceridemia, GFR already in the 3A or 3B stage. Tight glycemic and BP target, initiate cardioprotective therapy. Stage 3, subclinical CVD, high risk patient, high predicted 10-year risk of more than 20%, advanced CKD 4 or 5, add non-steroidal MRAs. There is a new drug called finerenone, non-steroidal MRA that has to be used. GLP-1 receptor antagonist, and aggressive lipid therapy. Stage 4, overt clinical disease, confirmed cardiovascular disease, clinical heart failure. Stage 4 or stage 5 CKD, team-based care, prepare for renal replacement therapy. This one table in the previous slide summarizes your management options. Now, the future of precision cardiorenal care, precision medicine, precision CRC, cardiorenal care. First, you recognize the phenotype. What is the phenotype? Classical proteinuric and versus non-proteinuric diabetic kidney disease. Number 2, dual screening mandate for UACR, urine albumin creatinine ratio, and eGFR. And structurally announced, understanding the RPS pathology, histopathology, and ischemic tubular damage. Do a renal biopsy and find out renal parenchymal versus renal glomerular versus tubular damage. Holistically, merging KDGO, kidney risk, with KFRE, failure risk, and CKM, systemic risk. 3 are there. KDIGO, kidney risk, I have shown you. That is stage 1 to stage 5. And then KFRE, kidney factor risk estimate, age, gender, eGFR, albumin punch, and get that risk. And you can use the CKM risk, which is in the previous slide. Moving from a linear kidney isolated models. Earlier, it is kidney only, nephrology only, physician, nephrologist. Linear model toward a systemic cardiorenal metabolic intervention, CRM intervention. This is called individualized precision cardiorenal care or precision medicine. Now, with this, the second part is over. Okay, now differential diagnosis and management of diabetic kidney disease, a clinical upgrade on diagnostic triggers, and the 4 pillars of therapy. Here in the management, you have got 4 pillars of therapy. Now, kidney disease diagnosis, diabetic kidney disease, histopathologically, diabetic nephropathy. We already contrasted them. Here, established via the kidney filtration and excretion marker like albuminuria and eGFR, strictly a clinical descriptor. Here we have got 1, the basement membrane thickening, 2, the mesangial matrix expansion, 3, the Kimmel-Steel-Wilson disease, and finally glomerular sclerosis. This is a histopathological counterpart. Now, you look at this matrix, hidden prevalence of non-diabetic kidney disease. Isolated non-diabetic kidney disease. That is, a diabetic patient can have non-diabetic causes of kidney disease. We forget it. The moment a patient comes to diabetes and kidney, oh, he has got diabetes, that's why he is having kidney failure. Not like that. There are non-diabetic causes also operating just like in a non-diabetic individual, in the diabetic individual also. What are they? Membranous nephropathy, IgA nephropathy. Most prevalent lesions are found. 60% of so 60% of the kidney disease in a diabetic fellow is due to non-diabetic causes. We forget to unearth them. Second one is isolated DKD. There are no other causes, only diabetes is the cause. In 13%, it is both the kidney diabetes and the non-diabetic cause together operating. Kidney disease in a diabetic patient is frequently non-diabetic in origin, which we forget to notice. Unless you treat that, the kidney disease will not get control. Now, you see classical CKD, that is the NDKD or mixed lesions. Duration of diabetes, more than 10 years, short duration. Diabetic retinopathy, present in vast majority of cases. Absent 80% of pure NDKD, lacks clinically detectable retinopathy. If a patient has no retinopathy and there is a CKD, it is the mixed lesion or NDKD. Urinary sediment. In fact, there is no sediment here, dysmorphic, non-dysmorphic proteinuria. That is, you observe the sediment, there are no red cells, there are no deformed RBC. Whereas in the NDKD or NADKD, we have got active sediment, microscopic hematuria, dysmorphic RBC are seen. And EGFR decline rate slower in the classical CKD, very rapid, erratic, rapidly progressive to ARF. That is the NDCKD. Proteinuria onset, slow and gradual, abrupt onset, full nephrotic syndrome in 1 to 2 years. This is the clinical discrepancy. Maintain a low. Now, what does it mean? Maintain a low threshold. That means raise your index of suspicion for a kidney biopsy when amber alert features are present. These are the amber alert features. That means a fellow with short duration of diabetes, lack of retinopathy, active urinary sediment, rapidly progressing nephropathy, you consider doing a renal biopsy and keep your threshold of suspicion for renal biopsy lower, and these people must be biopsied. Okay. Comprehensive cardio kidney protection. Cardio-renal protection. What do I do? Pillar 1, ROS blockade. Pillar 2, SGLT2. Pillar 3, GLP-1. Pillar 4, NSMRA. What are they? Each one we have to see. Pillar 1, ROS blockade. What is my problem? Afferent arteriole is widely dilated, efferent arteriole is constricted. Now what I have to do? I have to reduce the afferent arterial flow and increase the efferent arterial flow. How do I do that? Use the ACE inhibitor or ARP for diabetes in spite of hypertension or without hypertension and albuminuria. May or may not have hypertension and albuminuria. You must use the ROS blockade. What is the clinical mandate? Medications must be titrated to the highest approved and clinically tolerated dose. This nobody does. You prescribe Ramipril, 2.5 milligrams Ramipril. What does it do? I want to push this table. One finger, can I push the table? You have to give the maximally tolerated, highest approved dose. That means 20 milligrams of Ramipril is the upper limit of approved. If the patient can tolerate 20 milligrams of Ramipril, I must use 20 milligrams of Ramipril. This is what is the clinical mandate. Why? I want to prevent proteinuria at any cost. Okay, this is about the ACs, ARBs. The first pillar, ROS block. The second one is now grade 1A initiation threshold. Now this is the EGFR scale. 100 is normal. Less than 20, you require renal replacement, and this one, 10, 15 like that. What you have to do? SGLT2 inhibitors must be started very early. Use is primarily for profound cardio-renal protection. This SGLT2 inhibitors have shown profound protection on the heart and blood vessels, independent of the modest glycemic control. That means what? One person's glycemic control is good. No, why should I give SGLT inhibitor? They are expensive and I will reserve it later. No. If you want to have for the cardiac protection, you must start on the SGLT inhibitors very soon. As soon as you detect EGFR falling to a threshold of 20 or even when the EGFR is 20 or more, don't wait for the EGFR to fall below 20 and the patient requires renal replacement. Then I will start the SGLT inhibitors. No, you have to start the SGLT2 inhibitors in spite of the good diabetic control in the early renal disease of stage 2 or stage 3 itself. This is the pillar number 2. Number 3, GLP-1 receptor antagonist. This GLP-1 receptor antagonist is like this multi-pronged knife you will be having in your house. It is a knife, it is a corkscrew opener, so many functions are there. Like that, it suppresses the glucagon and stimulates glucose-dependent insulin release. That is one mechanism. Two, it manages the weight, drives safe, sustainable weight loss, is observed in GLP-1 RAs, reducing the systemic metabolic burden. Gastric regulation slows the gastric emptying to maintain steady blood sugar levels. So what happens if the gastric emptying is slowed? There is no sudden flux of sugar into the intestines for rapid absorption. So much so it is flattened. And finally, these GLP-1 are very active on the proximal tubular protection. In the PCT, via what channels? The ammonia channels, NHE3 channel. So they inhibit the NHE3 channel and induce direct natriuresis and reduces the fluid overload and sodium overload and modulate the renal inflammation. What are the 4 mechanisms of action of GLP-1 RA? 1, it suppresses glucagon and stimulates glucose dependent insulin release. 2, manages the weight. 3, gastric emptying is slowed, so much so sugar levels do not surge quickly. 4, it has got a direct PCT action wherein it inhibits the NHE3 channels and produces natriuresis and diuresis. So they must be used, GLP-1 receptor antagonists. Now, you have got the flow trial, semaglutide stops the clock. Semaglutide is a GLP-1 antagonist. It stops the clock. That means the worsening rate is decreased. There is a 24% reduction, 4% reduction in the primary kidney outcome, 18% reduction in the major acute coronary events, and 20% reduction in the all-cause mortality. Now, there was a trial going on semaglutide, and semaglutide was doing so well, they immediately stopped the trial and removed all those placebo patients into the semaglutide. The trial was halted because semaglutide was doing so well, they cannot keep the placebo arm until 5 years. Because it is not ethical when something is working so well in the early 1 year itself. There's no point in keeping the patients on the placebo just for the trial's sake, and the trial is stopped. This is very important. Kidney outcomes effect estimate, GLP-1 versus placebo trial, and then you can see the composite outcome is better, all-cause mortality is better, cardiovascular events is better, major acute coronary, but everywhere semaglutide did better than the placebo. So what you have to do? Now the pillar 4, what you have to do? You have to use 1, RAS inhibitors. Number 2, the GLP-1, the SGLT2 inhibitors. Number 3, GLP-1 receptor antagonists. And finally, the targeting the fibrosis. What is the problem? Tubular fibrosis. tubulolysis. That is the one causing all the cardiovascular problems. If I use NSMRA, that is non-steroidal MRA, targeting the fibrosis with a non-steroidal. What is NSMRA? There is a mineralocorticoid receptor here. That receptor takes the MR, that is the mineralocorticoid aldosterone. I go and block it with a selective NSMRA, which is called finerenone. This finerenone blocks the mineralocorticoid receptor. That means there is no accumulation of sodium in the body, no waterlogging. That's a better effect. And also inflammation and fibrotic scarring are stopped. Now, evidence-based grade 1A, base pooled by fidelity data, 23% reduction in the kidney failure, 30% reduction in the heart failure on those where we have used finerenone. Who are the patients who should get? eGFR should be more than 25, serum potassium should be normal, persistent albuminuria despite maximum RAs. That means the eGFR is not in the very terminal stage, like renal replacement. More than 25 is still there. And then serum potassium should not be more if you have to use MRA blocker. So serum potassium should be measured. It is normal. But persistent proteinuria is there and maximum tolerated RAS is already given. Proteinuria is not controlled. Then I give non-steroidal MRA. How does it work? It corrects the immune inflammation and fibrotic scarring. These are the 4 pillars of management. Now, when you write a prescription for diabetic kidney disease, RAS blockade, SGLT inhibitor, GLP-1 RAS, and non-steroidal MRAs depending on the necessity. Now, type 2, evidence-based surging innovation. Type 1, we don't have that much evidence in type 1. What all I told is mostly from trials on the type 2 disease. But now, there is one trial called the FINE-1 trial. In this FINE-1 trial, what happened? They are extrapolating the information we got, the positive information of these 4 pillars from type 2 to type 1 also. They are also getting benefited. Utilizing the urine albumin creatinine ratio as a bridging surrogate biomarker to translate long-term kidney benefit directly into type 1 diabetes also. What you have to do, every type 1 fellow, you must look at the albumin creatinine ratio every 1 year, starting from the 5th year of diagnosis. Now, FINE-1 translates finerenone benefits to type 1 diabetes also. Clinical results, 34% reduction in UCR over 6 months, greater relative reduction compared to placebo, 54% reduction. 54% of the treated patients achieved a more than 30% reduction in the albumin creatinine. It's a very important outcome trial. Now, you have got what is called the exceptional safety of this drug. Finerenone is exceptionally safe and hyperkalemia occurred but resulted in very low discontinuation rate, not much of this one. Otherwise, the aldosterone inhibitors are there, which are the classical MRA type of drugs which we have, and those drugs produce a lot of hyperkalemia. We cannot use them in CKD. Now here is a drug which doesn't produce much of hyperkalemia and which is very beneficial to the heart as well as the kidney. 2026 graded guidelines suggesting adding finerenone for adults with type 1 diabetes and CKD meeting the following criteria. What are the criteria? eGFR more than 25, serum potassium normal, albumin creatinine ratio, proteinuria persisting at finerenone. This is the latest guide. Now, once you do the demystifying the hemodynamic unloading, the eGFR dip, what happens when you use ROS blockade, SGLT2, NSMRNA, finerenone? Initially, the eGFR will drop. You may wonder, hey, I am treating the patient, but he is showing drop in the eGFR in the first 1-2 months. Don't worry. Immediately, the eGFR corrects to the normal levels. So, the eGFR drop is not to be afraid. Clinical mandate, do not prematurely discontinue these life-saving therapies just because the eGFR is declining to start with. Okay, you have to continue this trial. Now, what are the four pillars? Synchronized multi-targeted defense. Diagnose this is diagnose and differentiate. Number one, rule out non-proteinuric DKD from proteinuric DKD and early biopsy if required. Number two, maximize ROS blockade ACE-ARBs to the highest approved and tolerated dose, which you are not normally doing. Expand the base to pillar 2, SGLT2 inhibitors. Number 4, complete the total edifice or construction or the bhavana or building with pillars 3 and 4. What are pillars 3 and 4? 3 is GLP-1RA, 4 is NSMRA phenylalanine. These therapies are not mutually exclusive. No, no, I am giving this, I need not give, not like that. They are mutually exclusive. They act in a synchronized concert across different physiological pathways to defend the nephrons. Just like on the stage, the vocalist is there, the mridangam person is there, the violinist is there, the flute man is there. They don't play these music separately. They all together play the music at the same time. Then only it is a synchronized orchestra and the beautiful music comes out. Here also, early diagnosis, differentiating the two types of disease with proteinuria and without proteinuria, maximizing the ROS blockade, ACE-ARBs to the maximum, and expand the base to SGLT inhibitors and complete the 3 and 4 pillars like GLP-1 RAs and phenylalanine, which is NSMRA. This is the final this. Now, overcoming therapeutic inertia, the combined advantage of quadruple therapy, you see standard care, very rapid decline in the EGFR. If you use all the four therapies, there is a wonderful improvement here. Aggressive early stacking of four pillars, standard of care, SGL2I and SMRI, GLP-1 yield significant survival extensions. This is SMART C trial. Meta-analysis demonstrates that combining SGLT2 and GLP-1 introduces no supplementary safety concerns. You don't have to really worry about safety, and SMART C data is showing a wonderful additive and synchronized effect of all the four modalities. Now, structural integrity takeaways. Question 1. Maintain a low threshold for biopsy. Don't postpone biopsy in atypical presentations. What are atypical presentations? People who are late in onset, very rapid progressors, no retinopathy, and they have more cardiovascular risk and dying. Those have to be, the diagnosis should be based on the biopsy, early biopsy. Okay? Recent onset of nephrotic syndrome, rapidly progressive, absence of nephropathy, elderly people, female patient, beware of non-proteinuric diabetic nephropathy. The only way to diagnose is you have to do a renal biopsy. So, reduce your threshold or requirement for renal biopsy should be more. Number 2, push the limits. Titrate SGLT2s down to the EGFR 20 threshold and fiercely continue them until dialysis is initiated. Number 3, leverage new data, integrate the GLP-1 RAs flow trial and an NSMRA trial, FINE-1 trial to aggressively combat residual inflammatory and fibrotic risk across both type 2 and type 1. Hold the line, expect, monitor, and tolerate early hemodynamic drop. Don't stop with that. If the EGFR is dropping, EGFR is dipping, don't be a concern. Continue for 2-3 more weeks, it will pick up. They are clinical proof of efficacy. If the EGFR is dropping, that means your medicines are working. You must continue and not stop. Now, the future diagnosis. Now, what you have to now know is the part 4, the prognosis future directions, is a little more about looking into, peeping into the future. Not much useful to you at the moment, but I will quickly cover in 5 minutes in that. Transition to high resolution precision nephrology. Number one, CKM divergence curve. This is a normal progression, but majority of them are now progressing towards cardiovascular mortality. They are diverging from the normal standard movement. Now, what do I do? Clinical reality, the divergence, cardiovascular risk should be accelerated, accepted, and then the framework should be in the form of CKM syndrome. That is a cardio-renal syndrome, cardio-kidney syndrome. Now you have got the old guard ACE inhibitor, on that the new guards like standard SGLT inhibitor, GLP-1s, and the MRI, NS MRAs, and substantial residual risk that also has to be addressed in future. In spite of all the four, there is still some residual risk unaddressed, and we require newer therapies to address the residual risk. Now, you see the step core macro, EGFR, albumin creatinuria, AI digital pathology. Now, if you give the slide to the AI, it thoroughly scans the entire slide and picks up minor variations in the tubular architecture, in the glomerular architecture, makes a better diagnosis than an individual pathologist looking into 4 or 5 high power fields or 10 to 15 low power fields. The AI doesn't do that. The AI scans the entire specimen and will give you a better sort of information, and you have to use that. Step 3 is molecular multiomics. Do the genetic multiomic modeling, and finally the virtual biopsy is coming, and that is called the predictive models. These predictive models are virtual biopsy. Without doing a biopsy, you can predict what happens. Now, you see the albuminuric CKD only is the tip of the iceberg. Now, what is in the underwater is the part of the iceberg which is submerged. What is that? That is tubular atrophy, macroangiopathy. And you have what? This is the interstitial fibrosis. This is unrecognized. How do I get it? By doing early renal biopsy. Diagnostic blind spot. This you only get this much you are seeing. This part you are not seeing because there is a diagnostic blind spot. This illusion of safety, you think that you are playing safe, but there is a great hidden danger of tubular atrophy, microangiopathy, and interstitial fibrosis. So you have to look for the hidden danger, and early biopsy must be done. Now you see, illuminating the depth and expanding the biomarker arsenal. KIM1, LFAT have to be assessed. These are the micromolecular measurements. VGF and proteomic challenge collagen fragments have to be measured in future. These are all about futuristic therapy. Whole slide imaging. This is called WSA. Nobody can read the entire slide. If one has to read the slide entirely, all the high power fields of a microscope slide, it takes 1 year. It is estimated takes 1 year to scan. It works for 3 to 4 hours on the slide. Why? Because the area is so large. But you can now give it to the AI, where whole slide imaging is coming, convolutional neural networks are being used, panotropic segmentation networks automatically identify and classify complex renal microstructures, superhuman reproducibility. You give any number of times, it gives the same answer. You give to the pathologist, today he gives one reading, and another pathologist gives another reading. Inter-observer variability is very high in case of pathology. We have seen in one of our patients who is sitting here, a doctor's relative, one pathologist said no tuberculosis, and ultimately another pathologist identified tuberculosis in the boy. We treated with anti-tubercular treatment, the boy became better. This is because of lack of reproducibility in the human eye. So if you give it to the AI, it will not miss even a single lesion. Okay. Now you have got the multiomics, sRNA sequencing, spatial transcriptations, AI pathology imaging, clinical biomarkers, and patient phenotype is identified. Output, machine learning models integrate these profiles to predict histological diagnosis and better future. Now, endothelin pathways, genetic APOL1 pathways, aldosterone pathways, all are new therapeutic vanguard. That means we are opening into these three areas where new treatments could come. And finally, we have got the SGLT inhibitors plus atrasentan, which is a very specific drug for proteinuria and podocyte injury, atrasentan. The cardiorenal protection is being altered by the new trials on the atrasentan. This is an endothelial 1 inhibitor, the potent endothelial 1 inhibitor. Genetic risk, the damage and precision fix in next 10 years, you will have the podocyte cell membrane fixatives, drugs which act on the podocyte damage and block the APOL channel function and give protection. Inaxaplin is one new drug is coming. Rhodamine APOL1 inhibitor is coming. So many new drugs are in the pipeline. Now, what is the use for the patient? ASI advantage, and then you have got the breakthrough problems and NSMRA solution. Finerenone is already available. We are using that. Now, finally, if you look at the key examples here, primary target, ideal phenotype, and key synergies. I'm going to give you this PDF. You can read these things at leisure. The KDIGO roadmap, remaining clinical needs, unmet needs, how that being met. Then fulfillment of the precision nephrology is the watchword. Today, precision nephrology, precision treatment is the watchword. If you have any questions, you post me in the group. Since there is time up, we will close here.